The rousing endorsement, Gianni. I really appreciate that. I just want to say we started a psychedelic research group at NYU in 2006. And what was originally a reading group became a research group. And from that, multiple projects have happened. And it's really good to see so many people at Stanford and friends in the community doing this sort of work. So that's really fantastic. I'm actually not going to be presenting on the qualitative work today. I'm going to be presenting on psychedelic friction, which are 8 major controversies, debates, areas of friction in the discourses, in our research methods, and our clinical practices around psychedelic medical practice. But I do believe, just to circle the square on this, that the field has drastically overlooked the promise of qualitative and mixed methods research, has made major errors in jumping into conventional quantitative research where we take a top-down approach, take measures that were designed in other fields and sort of drop them in and say, well, it kind of measures the phenomena under study. Let's go with that. Instead of doing emergent hypothesis research from an emic, or rather bottom-up approach, looking at the themes that arise in participant experiences that might explain more complex, nuanced, or multi-level mechanisms that explain this question of like, what is happening with psychedelic medicine and why do we see such profound shifts, not only in consciousness, but in our scores for depression, anxiety, PTSD, substance use, et cetera. I'm going to speak for about 40 minutes, and I think we'll have to 20 minutes or the last bit for 15 minutes or so for questions. Is that right? That's a good time scale?
Yeah, perfect. And take your time too.
I'm going to share some slides. They're not super fancy slides, but I think they'll get the point across. And so if you have questions, feel free to, I think we'll take them at the end. Let me see if I can share this now. Okay, do you see the title slide maximized?
That's perfect. And if everyone has questions, feel free to put them in the chat and then we'll save them for the end.
That seems like a good way to do it. So I'm passionate about psychedelic medicine. I got interested in psychedelics in college. My boyfriend introduced me to Stan Grof's work through LSD psychotherapy. I was active in the East Coast rave scene in the 90s. There was no psychedelic research happening except for Rick Strassman's work. I started going to psychedelic conferences, such as they were. They were a lot of fun, but there wasn't much academic research to report on. And at the time, up until Hopkins came out with their paper in 2006, their first real study, for the next 10 years, we just poured over every nuance, every word of every publication that would come out, our team and others. It has, as you know, it's just expanded geometrically in the last few years. I cannot keep up with it. It's an incredible, it's like trying to drink from a fire hose. The number of institutions and publications and companies and projects and studies has made it impossible to keep track of. And that's both exciting as well as, in some instances, mildly terrifying. I'm going to go ahead and walk through a short introduction. Here are some disclosures. I've received funding from a variety of sources over the last 3 years. I'm now the Chief Clinical Officer at Psilocybin, which is my main gig, but I still maintain some projects at Yale and NYU and with Chacruna. I think most people here know this. Look, psilocin and serotonin are very similar in molecular structure, and each psychedelic has its own unique, let's say, signature of effect. Here we see psilocybin on a radial graph on the left versus ketamine on the right. Ketamine has higher disembodiment scores, whereas psilocybin has higher scores on visual alteration. Much of the controversies that I'm going to be focusing on today is in the realm of psilocybin, although they are generally applicable to other medications. Most of the work that I have done is with psilocybin. Psilocybin as a treatment for cancer distress, anxiety and depression, psilocybin-assisted psychotherapy to treat major depression at Yale, to treat obsessive-compulsive disorder at Yale, to treat alcohol use disorder at NYU. But also, I've done work in Healthy Normals, the religious leaders study between Hopkins and NYU, with priests and clerics and imams, giving them psilocybin, sort of drawing from the theological literature. I think it's also potentially applicable to the phenethylamine literature, including MDMA-assisted psychotherapy for the treatment of PTSD. I was formerly an MDMA study therapist on the MAPS trials. So if we just do like a quick overview here, this you guys have seen this before, but we're talking about controversies. I'm going to be focusing on the current controversies, but this is these practices with psychedelic medicines extend back into pre-Columbian history, certainly in the Americas, and we see that mushrooms are called in the Nahuatl tongue of the Aztecs, the flesh of the gods. There's been some fantastic talks on some of the anthropological literature regarding codexes detailing psilocybin use in Aztec culture, especially among the merchant class recently. We see this also in the Guatemala highlands of hundreds of mushroom stones that mostly were probably destroyed. These are some of the 200 surviving stones that have been brought together. In my 3-minute history, obviously there was everyone calls it the Psychedelic Renaissance, but there was, in the 1950s and 60s, a huge amount of psychedelic research that happened. Over 1,000 peer-reviewed clinical publications came out. When Nixon signed the Controlled Substances Act into law in 1970, it ushered in a 50-year drug war. We just celebrated the 50th anniversary last month. And not really much happened, except maybe at Spring Robe in the 70s, for most of my lifetime, in the late 70s, 80s, and 90s, until we start to see work coming out of Hopkins, our work at NYU, work at UCLA, and then Imperial College, New Mexico. And then we've just seen a massive proliferation going from a handful of universities to over 70 with active trials. I know that Stanford is doing some fantastic leading work at this point. This is from Nature this year. This is a number of psychedelic clinical trials, mostly in psilocybin, but a few, the orange squares of MDMA, and then some LSD trials coming along. There's obviously some novel new chemical entity work that is coming out of pharmaceutical companies. And then this is from Web of Science. These are just publications. Here you see that geometric curve in the last really peaking in the last 5 years. What's important, of course, is that to frame these 8 controversies is that we see massive effect sizes here on the right side of your screen. We see effect sizes for anxiety and depression, largely around 1. This means a 1 standard deviation improvement in your scores. Sometimes we do better. I mean, even in Robin Carhart Harris's depression article, we see, effect sizes as high as 3. I mean, you're seeing massive shifts in the curve as to what the average symptomatology score would be. And we see this in a variety of indications, a transdiagnostic trend. To give you a sense, most for treatments of depression, most standard antidepressants have an effect size of certainly less than 0.5, probably an average 0.3 to 0.4, when you include all of the published literature and meta-analyses. So we're seeing effect sizes that are 2 to 4 times on average, your leading conventional treatments for depression, for example. So I'm framing this as a debate. Debates can be annoying, but to witness sometimes. I was a debater in high school, and I kind of like the form because it seems to distill like the essence of what the controversy is. And I once heard from a friend who's an anthropologist. They said that if you really were an alien in a ship that came down to Earth and you wanted to understand our culture very deeply, or the subcultures within our culture, look to the controversy, look to the friction. That will really be an incredible entree point to understand what is really at stake. There are 8 controversies here. I'm going to give you I'm going to outline them here. The first one's going to take up most of our time. How do these drugs work? This is sometimes framed as, do you need to have a psychedelic effect in order to reap the benefits of psychedelic drugs? Debate between people like Roland Griffiths and David Yadin and David Olson, on the other hand. Number two, should the treatment for psychedelics be considered a combination therapy? Do we need the psychotherapy, or can we just give people the drug? Number three, if you're going to do psychotherapy, what theoretical approach should be used? There's dozens of different therapies. Like, what's the appropriate approach? Number four, what about placebo, and why can't we blind for it? And how do we possibly make claims in a blinded trial when people know they're taking a psychotropic drug? Number five, what are the credentials that are required? Is this going to be staffed, the future of psychedelic psychotherapy staffed by licensed credentialed psychotherapists, or just facilitators who are paraprofessionals, or nurses? And there's some pretty strong feelings on this point. Controversy number six, what training should be required? How much training? What's the training look like? Number seven, a continuation of that, but I think worth examining in its own right. What about experiential training, immersion training? Should therapists in training receive an experience of psychedelic medicine in order to facilitate psychedelic experience for their patients? And lastly, the perennial question in psychedelic work, and also psychotherapy and medical work, what works for whom? You know, almost all, this is the problem of psychedelics so white, that much of the recruitment and power in the community of practice has not necessarily generalizable to different populations with different specific experience and needs. So let's take a look at number one. This is the black box. I joke with my friend Jeff Guss, who was the former director of psychedelic psychiatry at NYU, that we'd like to joke that this is the psychedelic mystical black box. Like, what happens in that black box? People take psychedelics, and then incredible things happen on the other side, right? People have, across diagnostic classes, all sorts of, there's a litany of outcomes, but it's really unclear what the mechanisms are. So, you know, there's been really, I'm going to say, three major classes of mechanisms, mediators, if you prefer, but mechanisms of action. I'm going to try to summarize these as best as I can. I'm not a neuroscientist. I'm a clinical psychologist by training, but let me go through these and see if we can sort of identify what might be useful to take a look at. The first one will focus on the neurobiology. This actually came out, I think, just today. My joke is like, oh, so this is how it works, right? So some people on the line, so this is from Alexandrova and Phillips, sort of a model of neuroplasticity in both classic hallucinogens and with ketamine. And it's extraordinarily complicated and multifaceted. So, they, you know, in their abstract, they say there are complex interactions between the glutamate, serotonin, and regional synaptic homeostasis. It's part of a cascade of complexities. Let's take a look and see if we can suss this out a little bit further. So these are really sort of the leading foci for neurobiological mechanisms. We know with classic hallucinogens like psychedelic mushrooms like psilocybin or psilocin and LSD, that 5-HT2A is key, that there's receptor downregulation. We see enhanced cortical glutamatergic transmission in the prefrontal cortex. AMPA is involved. We have activation. We see reductions in the default mode network. The DMN, stemming from Robin Carhart Harris's work and others, has become potentially the most widely adopted neurobiological explanation for why it is that psychedelics work. When you're in the imaging machine, normally researchers give people tasks, like look at this cognitive puzzle, do these different things, and they image you. When the tasks are involved, the TPN, the task positive network, is engaged. But when the researchers realized when people had nothing to do in the scanner, they had another the default, another activity along the default mode network came online. And the DMN is associated with self-referential activity, potentially our sense of self, our ego, to use in Carhart Harris's word, like a neo-Freudian sort of frame, which I think is problematic, but nevertheless is potentially useful. The idea of sort of daydreaming, self-referential activity, this is orthogonal to the TPN under psychedelic experience, and we see reduced activity, potentially aligning with an idea that the ego structure itself becomes more liminal or egolytic, as Jeff Guss and Casey Apalios and I have spoken about in the past, and less rigid, and that in and of itself may be therapeutic. We also see increases in BDNF, which leads oftentimes to the neuroplasticity hypothesis. So the idea is that psychedelics are, I think as David Olson calls them, psychoplastogens, and that really they're involved in new learning. It's really about ending old habits and behaviors and opening up a quote unquote critical learning window where true synaptogenic, neurogenic growth, cellular growth can occur, and that pyramidal cortical neurons that have been atrophying under stress, under the stress of mental illness, depression, anxiety, trauma, etc., become re-enlivened and regrow. This allows for a critical learning window to give up old habits of behavior and take up new ones, old habits like stop drinking, and new ones like start meditating, or old habits like cognitive habits like depressive rumination, and to learn new ways of being with yourself, for example, like compassionate, mindful presence. Here on the right, we see a picture of the functional connectivity hypothesis. So this basically says that, normally the regions of the brain aren't that well connected to each other. I mean, there's specialized activity in the brain for a reason, but under psychedelics, all the different major, literal different regions within the brain start actively communicating with each other. And we see this through synesthesia. I've written about this in our qualitative research. But it also happens, across even further flung networks. And that is potentially a mechanism of action. And then lastly, we have the anti-inflammatory hypothesis. So Chuck Nichols and others have really pioneered this, and I think we're going to see more of this. Inflammation's been associated with bad health outcomes in a variety of different indications, including, of course, depression and mental illness. And psychedelics are very powerful anti-inflammatory agents. We see this, and sometimes psychedelics are being used in veterinary medicine. The problem is that there's such powerful psychedelics, anti-inflammatory mechanisms that they're hard to use as anti-inflammatory mechanisms because people have an psychedelic experience, which may not be what you want if you're just trying to reduce inflammation. But when people take a dose of psilocybin, it may be that they have global anti-inflammatory benefit, which may result in some of the benefits that we see for mental illness, for example, mental disorders. So in the question of how does it work, if we move beyond neurobiology and into psychology, which is the next class, what is the role of the psychotherapeutic intervention and efficacy? And look, I think it's important to say that in the way that this is a combination of treatment, there are at least 4 different platforms in a combination treatment. You have independent effects between the drug and the psychotherapy. You have the interactive effects, potentially enhance effectiveness of each. And then finally, and this is, I think, argued for by most senior teachers, if you're going to do a moderate dose of psychedelics like psilocybin in the course of psychotherapy or treatment to ensure safety, you really need to have a good set and setting, which includes a strong bond of trust and rapport with your therapy team, or the person at least who's going to be in the room with you. So there are various psychological mechanisms that have been proposed. On the left, I propose the common factors of psychotherapy. This is a sort of meta model across different psychotherapeutic, psychosocial interventions, the common factors model. Things like the therapeutic alliance. These things are commonly predictive of good outcomes in psychotherapy interventions without drug. And I think it's potentially clear that the common factors are enhanced by psychedelic medication. This has not been proven, but I think we can hypothesize that psychedelics may take things that would normally be therapeutic in therapy and put them on psychedelic steroids, if you will. So we see very strong benefits to the therapy, a strong therapeutic alliance as a curative factor, the provision of empathy, goal consensus, collaboration, good old Rogerian concepts of positive regard, affirmation. The client develops mastery of new skills as they psychoeducate to new ways of being. Experience of genuineness in the room, mentalization, and emotional experience. In addition to this, drawing from our psychedelic qualitative research, I'm proposing that there may be specific or more nuanced psychedelic-specific factors. And so this comes out of interviews with patients, but we see some interesting hypotheses, interesting anecdotal evidence that there could be some significant relational or attachment repair that happens during psychedelic trips. People see their deceased loved ones that parents, mothers, fathers, siblings, romances, rivals, and go through some powerful repatterning relationally, even in the work itself, as aided by psychotherapy and integration. We also see a profoundly increased range of emotions and expression. One patient said to me, "I felt every feeling I've ever felt to the nth degree on psychedelics." And there's something about expanding the range of emotional experience that could be psychotherapeutically beneficial. People do feel, commonly they report joy, bliss, and love. And those exalted feelings, not necessarily in a mystical experience, but just feeling love itself can be potentially therapeutic. What has been ignored largely in the clinical, more rigorous peer-reviewed literature is the body. Look, we know it's not just the mind, even though psychedelics is mind manifesting, but it is the mind-body. The body is a site not only of trauma, but potentially of healing. And patients have profound visionary, physical, somatic experiences. We know on psychedelics that they have enhanced interoceptive awareness. They consistently describe visions of going into their vasculature, into their blood, into their DNA. We have people having profound shaking, strong physical experiences. They have visions of ejecting fear from their body, fear of cancer. All sorts of things happen in the body that should be supported in the psychotherapy and could be itself a mechanism of benefit. People report revised life priorities. People report alterations to their basic identity, which could be potentially to get out of your skin and into a different identity, even for a couple hours. It could be very transformative. And then lastly, this is nuanced, and we maybe don't have time to go into it here, but I don't believe that in the context of a well-supported trial where there's a good team, good set and setting, the person feels a bond of rapport, that when it's common for people to have difficult experiences. This could turn into a bad, quote unquote, bad trip if it's in an unsupported setting, but these difficult experiences we find time and time again are resolved because the patient holds out a hand for support from the therapy team, and they are able to work through it without having to resort to rescue medications or other sorts of interventions. It is totally common in psilocybin experience for people to have transient panic, anxiety, fear, profound sadness, experiences of grief. This is even transient thought disorder. And these can be very challenging, difficult experiences, but I don't see these as necessarily a bug in the experience to be avoided and quashed, but rather a feature of psychedelics. They encourage the client, the patient, to experience feelings, including potentially intolerable feelings that they previously kept out of their awareness, repressed, suppressed, avoided at all costs, including trauma. We see this in the MDMA trial, and that the psychedelic allows them to experience it in a way where they come through on the other side, so that material that had been foreboding is metabolized in some meaningful way with the support of psychotherapy. Lastly, on this first big topic is how do psychedelics work? The third class of action is the psychospiritual mediator or the mystical experience hypothesis. We could spend an hour on this. I've given talks about the nature of mystical experience, and I'm fascinated by this. But I just want to say one thing here, which is that, what we see is that consistently in the studies, when people score high on the mystical experience questionnaire, the R-squared values suggest that it is a mediator, that it significantly predicts symptom amelioration for depression, symptom reduction for anxiety. Also, we see this in substance use studies as well. The problem is that this is held up as a totemic, as though the mystical experience is needed. Even if it's a substantial, statistically important mediator, what we see when you actually look at the variability scores is that, yes, the MEQ does predict reductions in depression, but it only predicts 13% of the variability, meaning 87%, the vast majority of the variability in depression scores, is caused by some other unknown factor. So the MEQ the mystical experience itself, while I think it's essential and important, and while one measure of the varieties of psychedelic experience, it is only one measure of mysticism. There's actually a whole literature out there. This is, I think, a huge untapped area for research. I've talked about different types of mystical experience that people have, including relational mystical experiences, experiences that are informed by feminist and queer theory, experiences that are deeply embodied. None of that's really caught on the current MEQ. So I think that we just have to have a more nuanced understanding of the psychospiritual mechanisms at play. So of the 8 controversies, the next ones are a bit shorter, so that's the good news. 2, what about the treatment itself? Is it combination or medication alone? So I touched on this earlier, that we have to leverage multiple effects, the drug effect, but also separately the therapy effect. And we've seen in combination trials for conventional treatment that usually the combination of a prescribed FDA medication and psychotherapy usually is better, for example, in the treatment of depression. But the therapy is nuanced. And here's my argument in favor of what this is. So what is the common phrase used? It is psychedelic assisted psychotherapy. And what that means is that the idea has always been that the psychedelic drug assists the psychotherapy in achieving change. That is what psychedelic or drug-assisted psychotherapy means. But that seems to have become inverted, as though the psychotherapy is sort of like this peripheral add-on. And I think that it's important to realize that in all of the trials to date, all of the groundbreaking work that's happened at Hopkins and Imperial and UCLA and NYU and elsewhere, that all of this is in the context of really intensive psychotherapy interventions. There are very intense clinician qualifications. They undergo extensive training. The actual therapy itself is quite long. In the MAPS trial, it's 80 hours of therapy. There's a lot of prep sessions. The medication sessions themselves are full-day sessions. There's a lot of integration, and they includes ongoing supervision. As Rick Doblin said, quote, "It's not the drug, it's the therapy enhanced by the drug." But because we live in a time where everyone's trying to figure out what's really needed, there's this idea of let's whittle it down. Do we really need the full component of psychotherapy? Do we need the full Cadillac of treatments, all of the hours, to therapists, et cetera? And I think there's good reason to take a look at this. Look, it is cheaper from an accessibility perspective to skimp on the psychotherapy. And these are valid research questions. How much preparation is really needed? Why not just one session? Why do you need 3 sessions? Why not 40 minutes? Why do you need multiple hours? How can we triage patients so that some patients, they could just get psilocybin and without any prep at all and just have a single integration session, whereas other people might have different, more intensive needs. What about some of I don't want to name names here, but can we substitute digital therapeutics, including, baby monitors, full app-based telemedicine where you're not having any human interaction at all for this? We see this in some ketamine provider clinics. We see this in some psychedelic companies. Look, the problem with removing therapy is that I think that to do it well and right, truly a component analysis or what's called a dismantling study would be required. And there are ethical risks to doing that. We'd have to think through very carefully what could be cut. Because there are iatrogenic risks, meaning that the intervention itself can be quite intense, and we don't want to pull the carpet out from under people without making sure that they have adequate support in order to do it. And it would be ethically problematic to pull away psychotherapy when it may increase the risk of a serious adverse event. For example, we see all the time suicidality occurring, especially in the trauma population, but, like that's not something that you want to play around with. This has been obscured by the discourse and the words that we used. So oftentimes people say psychedelic quote support, psychedelic therapy. Are they talking about credentialed psychotherapy by a licensed therapist, psychiatrist, psychologist, mental health counselor? There's a lot of obfuscation here. So we have to be really clear when we use words like psychedelic support, because some people mean that to mean psychotherapy and some don't. Again, some of the leading people here, so for example, in the USONA trial, in the set and setting protocol, they are providing what looks like, I think, potentially a psychosocial intervention, right? It's psychedelic support. But they do not require those, they're explicitly not providing psychotherapy. I do think that there's some problematics to this with the obfuscation around support therapy and psychotherapy, some of the leaders in the space. We should be clear. If everyone on your clinical trial is a licensed mental health professional, if they're psychiatrists and psychologists, it's likely that even if you're providing support, it's probably a type of psychotherapy. So we have to be very careful about what is being provided, especially because you see founder effects in these trials that when they get generalized in translational research to the community, yeah, the protocol says you don't have to have a master's degree in counseling to do this work, but if everybody in the trial had even a master's in counselor, I'm going to get to this later, has 3,000 hours of training, clinical training, right? I'm not saying even, like that's a huge amount of patient-facing hours. These are skilled and experienced people. Their experience should not be underestimated. So obviously, I'm passionate about this. I'm going to take a breath for a second because I believe in psychotherapy, and I've seen psychedelic medicine, how powerful and beautiful the work and touching and healing it can be for our patients and for myself. I'm a big believer in psychedelic therapy, and I'm going to just say that we developed Embark, which is a psychedelic assisted psychotherapy model at Psilocybin, the company where I'm the chief clinical officer, in combination with Bill Brennan and some other authors. And we canvassed 20 leading psychotherapy approaches, including classes of EBTs, evidence-based treatment, what we think of as more traditional psychedelic approaches, and different treatment forms. So to summarize, and we could spend an hour on each of these, but look, CBT has been used for smoking cessation by Matt Johnson, and what a lot of these take a standard existing proven EBT, and then they kind of add psilocybin to it, and that becomes the treatment, right? There's oftentimes more meaningful integration, right? But basically they're predicated on a platform of an EBT. We see this with motivational enhancement or motivational interviewing at my former team's work at NYU under the leadership of Bogenschutz for the treatment of alcoholism, alcohol dependence. We see this at ACT, ACT, in the work of Jordan Sloshower and Jeff Guss at Yale for depression. We see this in somatic practices, somatic experiencing, like the work of MAPS and MDMA, also IFS. And all of this is informed by a strong psychodynamic and relational frame. Also, we have very specific psychedelic approaches. So Bill Richards and the non-directive, stand back and let the medicine do the work sort of frame, inner-directed work. And forgive me, I'm not trying to be, I'm speaking in caricatures here. People have very nuanced positions. In the Mythhoffer's work in the MAPS trial, they use an inner-directed frame, which is an encouragement and invitation to the client to navigate the psychedelic space by looking to your inner healer or your inner healing intelligence Ask your inner healer, what do I do here? And let the inner healer guide you. So it's inner-directed work. And then the set and setting protocol, which is a cornerstone here of the USONA protocol and builds from the psychedelic literature. The standard model is a 2-to-1 dyad, although I think that that's starting to give way to other forms, including leaders in the couples therapy, group work, family therapy, and then Nielsen and Gorman's work with trans-theoretical psychedelic support through fluence in the community for people that have difficult psychedelic experiences. And so we designed a therapy that really looked to learn from these existing approaches, looked to learn from senior teachers in the space, senior trainers in the space, the leading models of therapeutic action and leading process evidence. So we developed the EMBARK model, which has 6 domains. The domains involve, and I don't have time to go into this, but I'm really passionate about this model. It pulls in the existential and spiritual effects of psychedelics. It brings in a domain of mindfulness and present-centered awareness and compassion. It brings in the body and somatic awareness into the work and prepares the client for that. It brings in affective and cognitive experiences of strong feeling and our thoughts about those feelings that do arise. It brings in our relationships, relationship with a therapist, but also relationship with your primary partner, your family, the people in your lives that consistently comes up in psychedelic medicine. And then it has a relapse prevention piece called Keeping Momentum, the K in the EMBARK acronym. And all of this is guided by like 4 major cornerstones, which we see across treatments. The work should be trauma. We provide 4 types of care, right? It should be trauma-informed care, culturally competent care, ethically rigorous care, and collective care. And so we have modules developing and a manual that develops each of these. So I think that, when we think about this appropriate psychotherapy model, we have potentially dozens to choose from. And I think that really we're at the beginning of what might become the leading psychotherapy approach to psychedelic psychotherapy. Number 4, controversy. What about placebo? This is a real quick one. The problem here is that even if you try to do everything in your power to quadruple blind your study, it's really hard to blind a psychotropic drug. Even if you put it against an active placebo versus an inert placebo like a sugar pill and give people niacin or methylphenidate or a low-dose comparator, both of them and their therapy teams still identify oftentimes that they have received the psychedelic. Hopkins has gone to great lengths to try to obscure this by telling participants, you may get one of 20 different drugs, I think it's 18 different psychedelic drugs, at any of different dosages. And so they really have no idea what they're going to get, including the therapists don't know what they're going to get in one trial. But nevertheless, when we do double-blind, RCTs for FDA-enabling trials, it's really hard to do this. One option would be to do a standard of care comparator, as we saw in the recent escitalopram versus psilocybin study coming out of at the New England Journal of Medicine. That was a very problematic results trial for a number of reasons, but nevertheless, you see a standard of care comparator or a dose response study would be an alternative methodological approach. Number 5, what are the credentials that you need? Look, I think that this is really about who's going to have some ownership of the actual model for the service delivery of psychedelic treatment in the future. Is it going to be clinics or health systems that are owned by psychiatrists, or are psychologists and mental health professionals who are not prescribers going to have a meaningful input? Are the clinics going to be staffed by I don't mean this in a derogatory word, but people use it as lower level, or people who have master's degrees rather than PhDs or MDs. And we've seen the FDA put a clinical hold on a clinical trial recently because they said that master's level clinicians could be, clinicians in the study. At the MAPS trial, they recently released that clinical hold, not requiring PhDs or MDs to be involved necessarily in the room. What about paraprofessionals using Oregon's 109 measure? So who's going to be really owning this? And to the extent that we are providing psychotherapy, I have to say, as a psychologist, it's upsetting to me when I work with an ER doc or an anesthesiologist who has profound expertise in their area of study, but they come and they do like a weekend workshop on CBT or a weekend workshop on a psychotherapy module and think they know how to do psychotherapy. It's not a one and done sort of training. Psychotherapy is like you do one and then you do 1,000 and you actually build skill quite a bit over time. And we see this in studies of therapist effects that, therapists really do have 3,000 hours of training. So I'm biased. I'm a psychologist. I believe that psychotherapy training is really essential here. And this is backed up by people like Bill Richards and others, but I think that it's really going to be an ongoing question because we have a shortage of psychotherapists in the United States and around the world. So how are we going to actually staff and scale the psychedelic medicine future? No matter who does the work, what about the actual training for the psychedelic itself? So MAPS, I did the MAPS training, was originally 120 hours. They've gotten this down to 100-hour training, but it's not see one, do one, teach one. This involves like usually a certificate program. Compass Pathways has a similar 100-hour training. At our program at Embark, our program's a little bit more focused on a specific diagnosis for a specific medication, and that's 70 hours, but there are out-of-class readings and additional work that has to be done. There's also, in most of these models, ongoing supervision and a community of practice model that we're trying to invite. So it's not like you just do a weekend or a week-long training workshop in psychedelic therapy and then you're free to go for the rest of your life. And we know that CEUs is not necessarily continuing education credits. It's not necessarily the best way to ensure that the people are really in a embedded community of practice over time and actually meaningfully supported in doing psychedelic work. And other schools, they provide general practitioner trainings that are many hundreds of hours. Timmerman, Watson, Dupuy have put forward a psychedelic apprenticeship model. These are usually more robust in the sense that they're training people to do psychedelic work for dozens of indications, not like one particular clinical trial, but to be community practitioners. There's so many challenges here, right? There's no current licensing infrastructure in place. There's no standardized training. There's no standard. And different guilds get into squabbles about who's going to own this meaningfully. I do think that that this level of intersubjective work does require an experienced provider. This is not something that a very short online training with somebody who doesn't know how to do psychotherapy could just jump in and do well. That might work out for 4 and 5 patients, but one of those patients is going to need a deeper level of support with a more skilled provider in order to avoid what we see in psychedelic work, which is the unique behavioral risk of really difficult experiences for some individuals, especially at moderate to high doses. What about this issue? So MAPS has an MT1, MT2 clinical trial, which is an open label, healthy normal trial, where people like me were given the opportunity to legally get MDMA as part of my training in order to be an MDMA therapist in a trial to treat people with severe PTSD. The thought is basically, in order to help facilitate a non-ordinary state of consciousness for another person, you yourself should have had the experience of a non-ordinary state of consciousness. Look, the dominant thinking in the field is that this is like considered essential by senior teachers and trainers. The FDA put a clinical hold on this study for complex reasons, probably not having to do with this. They recently released that clinical hold just a few months ago. But almost none of the trainings that I'm aware of provide a legal mechanism by which clinical trainees, can have an experience of psilocybin in order to get psilocybin, including all of the university trials, all of the industry trials. Many of them, including our work at Cybin, we are substituting holotropic breathwork, which was developed by Stan Groff, not because it's a substitute per se, but it is an excellent experience of non-ordinary consciousness and provides the experience in dyads of caregiving and caretaking. in a psychotherapy model, but we need to figure out a different training mechanism to allow for experiential and immersion training to happen in a good way, in a legal way. It's a real challenge. And I'll conclude with this, which is the systemic issue of what works for whom in psychotherapy. Look, there are unique. I'm editing a book right now with Clancy Kavnar and Bia Labacha called Queering Psychedelics: From Oppression to Liberation in Psychedelic Medicine. And we're looking at 35 different chapters from authors on the intersections of LGBTQIA plus experience and psychedelic consciousness and culture and medicine. And what's interesting is that, look, there is a huge amount of research that there are unique minority stress pathways for gay and lesbian individuals, for bi and trans folks, for racial and ethnic minority folks. We see that in multiple studies borne out that it's not because people are gay that they have higher rates of depression, stress, and anxiety. And substance use. It's because they're subjected to massive amounts of stigma, experiences of discrimination, and messages of rejection from their family and community that lead to higher cortisol levels throughout their life. This is an important thing to look at. In our recruitment policies in psychedelic research, we propagate, and in the power dynamics of setting up clinical trials, these tend to be predominantly led by white cisgender men. We see this consistently throughout. We see this in our patient recruitment practices. And so we don't know, for example, because our subgroup analyses, the cell sizes are so small, whether psychedelic treatment works as well for racial minority populations as it does for white dominant racial populations. We don't know if it works as well for sexual and gender minority individuals as it does for their straight counterparts. We actually just have no idea. No one's funded the research yet. There's insufficient sample size. And so when we ask what works for whom, the means of the production of new knowledge, the actual funding for these studies privileges certain forms of knowledge, and marginalized, oppressed populations tend to get short shrift because the research data actually doesn't apply to their unique experience. So when we try to answer the question, do psychedelics work for this group of people? The answer is, we don't know, but we should. And I think it's a moral imperative for us to reform our systems to reflect that. So I'm going to close by saying these are what I think are the most hot button, controversial, interesting topics in the field today. They underline much of the rancorous debate on listservs and in forums. It's really lovely to be able to speak with you all about this. And I think we have a little bit of time for questions at this point. So thank you so very much. It's good to speak with you all. I'll stop my share and we can look at each other now.
I'm clapping for the collective here.
I'm hearing it. Thank you.
Thank you, Alex. It leaves a door open for a ton of questions. I mean, you just gave us 8 places to start. So, there's a lot. I will leave it to anyone who wants to either raise their hand and chime in themselves or post a question to the chat. One, it kind of is gets at what Vikram is asking in the chat. What I'd be curious is, if you had, say, unlimited funding and 2 lives or additional time and no million other responsibilities, given everything you just said, what trial would you design? Who would be the therapist team? What would be the drug? How much therapy time? Like, do you have a vision for what would be the best kind of clinical trial?
I think for these 8 controversies, they all potentially are totally valid, answerable. I mean, there's some stickiness, but they're valid, answerable questions. I mean, we can design the appropriate method with sufficient funding. And look, I think for the first time ever, both Matt Johnson and Ben Kilmendi at Hopkins and Yale have received NIMH funding, I think for the first time in decades, to do psychedelic research, which is fantastic. I'm on Ben's team at Yale, but I think that like in terms of funding or research priority, I think it's an open question as to whether or not what is the value add potentially for psychotherapy and level of psychotherapy and the hours of psychotherapy as compared um, to excuse me for a second, a psychedelic intervention that doesn't include psychotherapy, or that only includes like very minimal psychotherapy, or only includes very minimal psychedelic support from like a paraprofessional. I think that what you're going to see in those trials is it's actually not a Gaussian curve. Most of the people might just do almost nearly as well. I don't think so entirely. If it were true that mushrooms cured depression, we'd see a lot of people in the Grateful Dead and Fish communities with much lower rates of depression, but that's not true. I think it's the combination. I mean, and I say that lovingly. That's the combination of the psychedelic and the psychotherapy, I think, has shown why we see such strong effects in our clinical trials. But I think, these trials can be run. The problem is there's no financial incentive for an industry or an academic sponsor to run these trials. Now, I think that there's some talk to fund them, frankly. And I think that you're not going to see, I think the real problem is that, the FDA has a 1,500, using ICH guidelines, a 1,500 subject safety database. I think it's entirely possible that if you ran that trial in 1,500 subjects, there would be very few safety events. But I think if you had like the bare bones, the bare bones trial, I think that you would see some greater likelihood of adverse events. You might not see it in a cohort of 10 or 20 or 30, but you might see it in the hundreds. And we do not want people running out of the room during these treatments. We do not want people with increased risk of suicidality. We do not want people with difficult, undiagnosed experiences of mania that don't get picked up in aftercare. These things are real risks that need to be dealt with, and the current structure in place has a lot of bootstrapping. The question is, which bootstraps do we need and which ones don't we?
Yeah, thanks, Alex. Given that there's kind of a flood of good questions, instead of me paraphrasing them, I'd actually ask people use the raise hand function if you're willing, and then hop on and ask the question yourself, and that will help also order it. So while you're doing that, I'll ask one from Julia, which is thoughts on the important differences between the psilocybin facilitated altered state versus one that might happen in, say, breathwork, holotropic breathwork, or another shamanic technique.
Wow. I mean, like I didn't read the question, but I mean, I think that holotropic breathwork is an incredible modality. I think it does help when it's administered by somebody who really does breathwork well. And I think that it doesn't necessarily have to be Groffian, holotropic breathwork, shamanic breathwork, and other breathwork forms can be very powerful. I do think that some people don't seem to get an effect, or they don't really have much of an effect. I think they might not be breathing deeply enough or long enough to have an effect. It requires quite a bit of work. But I don't think the two are necessarily can be properly substituted for each other. In the same way that, look, like for UCLA, like different dosages of psychedelics are not substitutes for one another. I mean, people have such profoundly different experiences. I mean, UCLA's cancer study used 0.2 mg per kg. We used 0.3 at NYU mg per kg. Hopkins used 0.43 mg per kg. And people had really different experiences. Everybody benefited. But, like the difference between 0.2 and 0.43 mg per kg of oral psilocybin is really really profound. So there's massive differences even within the same drug and the same basic treatment milieu based upon the elements of set and setting and the elements of dosage. So it's just kind of astounding and really exciting because it's just not going to be simple. Like it's just going to be like very complex, I think, for us to study.
Thank you.
I think in the fish study, they also used 0.5 mg per kg.
Yeah, with
Yes.
varying outcomes, I imagine. Yeah.
Um, I guess no one is interested in raising their hand, so I'll keep reading them until someone does. But can you comment on the ongoing OCD trial with psilocybin, about design, therapy component, other features of it, how it's going so far?
Yeah, that came from me, Gianni. So, Alex, that was a great talk. Hi, it's Rob Malenka. I'm a professor at Stanford.
Hi.
And I actually run in my spare time an OCD research foundation. So I've heard about I don't know if it's being funded by Cybin or a different company, but I've heard about a psilocybin and OCD trial. So I'm just interested in where it stands, what the clinical design is. I mean, is it one psilocybin experience with the therapist? Is it several, et cetera, et cetera?
Yeah, absolutely. And it makes, the team presented an interim poster recently with some findings for OCD that I should post in the chat, so you can really take a look at it. And I can actually pull up the clinical trials.
But I don't want to take everybody's time. Just a very quick answer is fine. I'm actually interested in the design of the trial.
Yeah, so it's 30 participants. It's still ongoing. We're still trying. It's a randomized parallel study design, and there's for the treatment of obsessive compulsive disorder. Excuse me, OCD, obsessive compulsive disorder. There's an active placebo, niacin, and I mean, I guess the takeaway that I have here is that. The interim results are very promising. As you guys know, treatment of OCD is very difficult. My role in this study is running in-depth qualitative interviews with the subjects who've undergone the treatment, and it's incredible. Some people are having like really profound trajectories of remission entirely, or certainly response. I think that we're still like under a dozen subjects, and the NCP poster came out with some findings, but I believe, and I think that Kelmendi has received funding and is working towards more OCD research in this field, building on the early work at the University of New Mexico, where we see really strong drop scores in the Y box, which is the standard gold measure here for OCD. I'm still learning about OCD, so I'm excited for that. But I think that we might see this becoming a major treatment in the future. I'd be surprised if it weren't picked up by industry soon. Yeah.
Okay, thanks.
David, I see you. I know you're there. Would you mind asking your question?
Sure.
Hi, David.
Thanks. Is the raise hand feature working? I may just be bad at Zoom. I think I see. Oh, there are a few raised hands. I'm just bad at Zoom. Sorry about that. But Alex, thanks for your talk. I really appreciate it. Good to see you again. Have been thinking about some of these controversies a lot since starting my postdoc at Hopkins and getting a sense of the model and the therapeutic environment here for sessions. And I've noticed there is more emphasis on maybe more of a guide and monitor type role as opposed to maybe a more directive or psychotherapeutic level of support. And I find myself conflicted and confused about this. On the one hand, curious about just if simple human contact is good enough to get people through the sessions and power some really meaningful outcomes. And on the other hand, as someone who's had some basic training in psychotherapy, I do have a bias there and wonder how best to advocate for people with training who can be there when things go wrong, but I'm not really sure how to articulate that. I think in society in general, that's a little hard to articulate some of that invisible harm.
David, my experience, my understanding is that at Hopkins, they use a two therapist model, but one person has to be a credentialed psychotherapist, and the other person could be, they're usually like a trainee, like a resident or somebody who may have less experience, but still has some graduate training in a related field. Is that right?
It's a single therapist with training, and then it's the other individual could be anyone really. Usually, either someone with therapy training or even like a research coordinator without any sort of clinical training.
Yeah. I think it's a little complicated. Look, Mary Consimano and Bill Richards are friends. I've often joked that it may just be that Mary and Bill are the two best therapists in the entire world when they give psychedelic medicine, and that's one of the reasons why we see such strong effects coming out of Hopkins' early research. I think that a model, I feel like this is part of the obfuscation problem where if, and I don't mean to represent what Bill has proposed, but this sort of like idea that we just provide like a monitor, like the person in the room is just a monitor, which really derives from discourse around behavioral psychopharmacology and like clinical trial work, rather than coming out of the discourse of psychology or psychotherapy. And I think that those discourses and those words are important. If you're in the room with two monitors, but one of them is a psychologist and the other one is a medical resident in psychiatry, like you may not be requiring that they have all of that thousands of hours of experience, but they do, and that informs the quality of their intervention. And look, psychotherapy is not just like shoving CBT down somebody's throat, right? I mean, you can do a hyper manualized psychotherapy, but you can also do psychotherapy in a way that is a light touch, and yet the presence is very important. And in fact, some of the best therapy might be in that vein. It doesn't mean that it's not psychotherapy just because you're not hitting bullet points, right? So I do believe that one of the studies that we could run would be like, what is the triage, right? Like for which patients is, to your question, David, is well-intentioned human contact and some basic support training sufficient? And for which patients do they require more? When I do 3 sessions of 90 minutes of prep before the first psilocybin or the first MDMA session, something comes out in the enrollment period, new information comes out in the first session, new information comes out in the second session, and sometimes by the third session, when we're still trying to figure out if this person's ready to take the medicine, like a whole other thing will come out, like a massive childhood trauma, sexual trauma, major life event that they hadn't even told us, that then becomes the emergent theme of the treatment that we would never have picked up on ahead of time. That may have been a yellow flag, frankly, if we didn't have adequate prep work. We saw that in a lot in the PTSD trials. So I think it's going to be an ongoing tension for a long time.
Thank you.
Thanks for your work, David. It's nice to see you.
Thanks, David. I realize I actually can't even find the raise hand function, so that was hypocritical. So
I see Melinda and Vikram both have hands up.
Yeah, let's go ahead. Yeah, I think I set people up for failure there, but some people found it, which is excellent. So yeah, please, we'll go in order. Vikram, go ahead.
Yes, thank you for the wonderful talk, Alex. I really appreciate it. I was wondering about the OCD trial. What therapy modality is utilized? Is it exposure response prevention? And going along those lines, I mean, is there a strategy when considering treatment or designing a study on picking the therapy modality to utilize for the patient population?
Could you say that last phrase again, Vikram?
Oh,
Picking the therapy modality for the
patient population, for the study population, or for the specific illness that you're trying to address. Is it primarily CBT focused, or is it catered towards a specific illness, like exposure response prevention for OCD,
right?
CBT for borderline, things of that nature?
So there's not an exposure response specific component to the intervention in the trial. It is a very intensive inpatient trial, though. They do spend three or four nights on an inpatient unit. So it's quite a stay. The the work is most of the sort of psychotherapeutic intervention, and I'm not, to be honest, I'm probably not the best person to speak to this. I defer to Ben Kelmendi and team when they write this up, but because I'm not actually in the room, I'm doing interviews with subjects afterwards. So their therapy model and work with clients is one to support them through the experience, but it involves some psychoeducation about OCD. But I think that really they're trying to leverage the psychedelic experience itself. So yeah, I'm not sure that really answers your question, but I feel like there was a second part to the question that was it about OCD specifically or about some other aspect in general?
Thank you. Actually, that addresses the question. I was just wondering if there is a specific modality for different illnesses, but yes, I get the sense that it's more of a general psychotherapy. That's
yeah, I think that specific modalities for specific illnesses really is crucial, and this is a technique that we've brought up in our work to develop Embark, which is that when Embark, like CBT and like the unified protocol, which comes out of the cognitive behavioral literature and Barlow and others, in the unified protocol, and this is a transdiagnostic approach, but then you can adapt that protocol for a very specific indication. I think that we can do the same for psychedelic-assisted psychotherapy. So Embark is a psychedelic-assisted psychotherapy that we have adapted in a manual it's about 100 pages right now for the treatment of depression, separately for the treatment of alcohol use disorder, separately for the treatment of anxiety, separately for the treatment of COVID-related distress and symptoms of depression amongst frontline healthcare workers, which is a study that we're starting here at the University of Washington. It's a psilocybin study to treat COVID-affected frontline doctors and nurses who've been on the front lines of the pandemic and are suffering. We're treating them with psilocybin. So we have a specific adaptation of the model for that. And each of those adaptations as a psychotherapy has specific evidence-based techniques that come out of the literature for that indication. So it can get quite nuanced and specific.
Thanks, Alex.
Thank you so much.
I think if you're there, Melinda, go ahead and you can chime in.
Hey, I'm here. Just to let you know, the raise hand option is option plus Y if you're on a Mac.
Thank you. I think it's also in the reactions. If you hit the reactions, it's there. I just learned that. Thank you, Pearl. But also thank you, Melinda. Go ahead.
I thank you so much for the provocative talk, Alex. I have two questions. The first one is relatively more pedestrian. So you mentioned this concept of functional blinding. And I'm wondering, in the past trials you've read and in your experiences, have you encountered a relatively more promising alternative for a placebo that may produce, similar experiences as a psychedelic? And the other question I have is, you also mentioned that a lot of the psychedelic therapeutic effects may not be translatable to minority demographics. And I'm wondering, have you ever thought about it got me thinking about, right now we're focusing on an effort mostly in the US and the UK, relatively developed countries, but what about overseas in the developing world? Do you think that's a functional alternative to perhaps other cheaper drugs that are already there, like SSRIs? What infrastructure may we need to really implement this and get it going in those countries as well? Because presumably we don't want to neglect them either in this process of development.
Yeah, I mean, you're it's nothing like an easy question at the end of a talk to tackle. I mean, it's probably one of the most important questions today, which is the issue of translation of what we're learning around the globe. I used to be a student in a graduate program at Columbia with Helen Verdelli and Paul Farmer and others who were doing some of these translational psychotherapy research in other countries and looking at task shifting and other WHO supported ways to look at not just scalable, but like cross-culturally translatable models for the treatment of diagnosis and treatment in complex cultural contexts, which, by the way, many of these cultures have extant traditions or no longer extant traditions of psychedelic use, since we see psychedelics even in European countries, for example, for millennia. I think it's a massive issue and problem. The biggest stumbling block, I'm answering your second question first. The biggest stumbling block is that this is going to be an expensive treatment. When you do the valuations, and I have seen the economic models, SSRIs are cheap and generic. Psychedelics, even if you use cheap generic psychedelics, the entire package, like it's 80 hours of psychotherapy, for example, is expensive, and it doesn't scale, and it's not going to be accessible in our existing delivery care system, and not just in low and middle income countries, but in the United States as well. So the problem is the cost comes up front, and then when you look at the benefit, you see long-term benefit potentially up to 6 months and a year for psilocybin studies and MDMA studies repeatedly. So it's a great upfront investment for long-term morbidity issues, but it doesn't. But you have to put the money in upfront, and it's more expensive. I think that an entire subfield of inquiry should be developed to answer your question, which I think is really important. To go to the somewhat simpler but also potentially insoluble problem of blinding. The way that I thinking about blinding is that it's really about if we have to pick an active comparator, let's pick the active comparator that has the most likelihood that we're going to see a differentiation from, right? So we want to make sure that, we want to design the trial to maximize the difference between the active placebo arm and the intervention arm. We've seen time and time again that low dose psychedelics don't differentiate as well from moderate dose psychedelics as things like niacin or methylphenidate, Ritalin. It could be that low dose or ultra low dose psychedelics that provide even like a threshold effect that people feel like they're getting something, still has some therapeutic benefit. And so it's really not the greatest comparator, because you want the placebo to give no therapeutic benefit in order to maximize the statistical difference between the arms of your study. I don't actually honestly know what to do about this, and I don't really have any bright suggestions. I think that it would be important as a methodological assessment to have in a triple or quadruple blinded study for the independent assessors and for the therapy team, for the monitors, whomever you call them in the room, to independently mark whether or not they think the person received the intervention or the control, the placebo. And that's, Hopkins and other groups have done that. That's really best practice. But when we do that, we see that most of the time, the clinicians can guess to some extent. They get it wrong sometimes. And I've been in treatment rooms with the person, and with my co-therapist, did they get the medicine or did they get the placebo? I really don't know. So that does happen, but it happens in a minority of circumstances, which is really not a gold trial blinding. So a gold standard blinding. If anyone has a novel idea, I'm all ears. I don't really have any other suggestions for great blinds. I mean, obviously, if you do if you tell people they could get 20 different psychedelics, and then that does confuse things potentially if there's only really one medicine under study. So that's a more complex design like that could confuse subjects, but it does complicate the picture clinically when you have no idea if you're getting salvia or ibogaine or DMX or LSD at any dose. It's really not the same as doing a phase 2 or phase 3 trial with patients where you're really trying to train both the clinicians and the patient for a particular type of experience. there's too much uncertainty in that, and that's potentially not clinically efficacious. Although it might solve your blinding issues, give you eke out a little bit of a difference there.
Yeah, thank you so much for that extended answer. I have a follow-up question to what you just said. So is the Hopkins actually like just telling the patients that they'll be receiving like out of a set of, you said like 20 something or 40 something different kinds of psychedelics? Are they just being told that, or are they actually being given different doses and different formulations of psychedelics?
Hopkins has done like so many different trials, but I'm thinking, and I don't have the reference at hand, of one study I believe Roland and Matt Johnson were authors on, where I think they just told participants and clinicians that in the trial they could receive any among the following list of substances. I think that they were administering psilocybin in this trial, but the idea was to obscure what the actual design, dosage, and study drug was. But they weren't actually giving the full round robin of all of those different substances. Yeah.
Got it. And I'm wondering, sorry, I'm taking up the space, but just for a last aside, I'm wondering whether it would actually be beneficial to not give like maybe like 20 different kinds of psychedelics, but administer other substances that have psychedelic effects, but don't really give the therapeutic effects that psilocybin might confer. Yeah, that's just like something like food for thought, I suppose.
Like which substances?
Let's see. I guess like some I guess some like research chemicals do confer some of those effects.
I mean, I think the problem is that my question is the problem is that of the 250 compounds that Alexander Shulgin synthesized, of the hundreds of compounds that are being studied, it's not clear that any of them are not therapeutic. So, you know, whether you put DMX or salvia or ibogaine or 2-CT7 or some sort of N-bomb or other chemical or a variant, they're all potentially therapeutic. So I can't imagine a psychedelic that's non-therapeutic. I mean, there are I think that's why like Ritalin and niacin have been used. They cause, you know, people have effects, but they don't necessarily are known to cause like antidepressant, for example, benefit. But I think, you know, I'm not a psychiatrist or a pharmacologist or a chemist, so there might be some other folks out there that know more about this than I do for sure.
Great, thank you so much.
You could compare like you could do Ritalin plus niacin plus like psychedelic wallpaper or something. Anyway, thanks for answering all these. Do you have time? I want to be respectful of your time. I know Wendy had a question, and then maybe we can wrap it up after that. Would that be all right, Alex?
I think that sounds great. I know it's getting late for some folks, so we should all go and rest or have dinner or whatever. Yeah.
Well, thank you. Thanks for making the time to take on one more question. I put it in the chat as well. You know, first off, just thank you so much for this talk. Hearing about your experience in psychedelics and also passion for psychotherapy and really studying it is awesome. I'm a psychiatrist at the VA, you know, teach at Stanford, and also am part of the study that's going to be happening soon. So I really have been grappling with these questions around the lineage, you know, of where these medicines came from and how different it is from our current paradigm in allopathic medicine, as well as in, I think, Western psychotherapy. And hearing you, you know, just kind of throw in mentions of like feminist theory or other potential mechanisms for change, you know, I'm curious, like how in working in a large system or like a for-profit company, how do you navigate some of the tensions with I guess what's owed to Indigenous people, you know, for the original medicines and the intellectual property, the ways that this is held in groups, right, in so many cultures, and maybe that's a way to grapple with the huge financial cost of individual therapy. Curious about your thoughts.
Yeah, probably one of the most, and there's a really interesting, it wasn't double blind. There was an article 2 days ago on what does the psychedelic industry owe to, in terms of indigenous reciprocity. And so, look, I think that the debt that we have, let me try to approach this differently. The world would not have psychedelic mushrooms if Maria Sabina, as a Mazatec shamaness, healer, did not speak with the little spirits of the mushroom, and that was not so very long ago. Giving the credit to that to Gordon Wasson is like another way of colonizing indigenous experience. I think that and I would also want to say, as a person with much European ancestry, the European pre-Christian tradition of mushrooms is like not very well documented, but is probably a pan-European tradition going back to the Kaikian in Greece. Look, psychedelic substances are on the 6 inhabited continents of the world. The first peoples of all nations had probably access to them in some way, form, or another. And there is documented anthropological and archaeological indications of use basically everywhere that human beings have existed in some form or another. And I don't want to make too broad a stroke here because I'm not an anthropologist or an archaeologist, but this I don't think I'm really overstating the case that this is actually like a deep and hidden history for all of us. I look to some leaders in the field that are trying to build bridges between the existing academic community of psychedelic research and organizations, nonprofit and for-profit in the space, and indigenous communities. So I know that I've talked at some length with the folks at Chacruna on their IRI, the Indigenous Reciprocity Initiative, which was launched last year. I was part of that first meeting. At Psybin, we've sponsored, largely sponsored the Sacred Plants in the Americas conference that was held to talk about indigenous wisdom, lineages, and the history of psychedelic plants. But I think, and other leaders in this space include some organizations like Doc Bronner's and like River Styx, that both River Styx has a Indigenous Reciprocity Fund. True reciprocity, though, is not just about giving money to a fund, and most academic and requires like a more meaningful and deep engagement with cultures and people that for whom these traditions are alive, well, and extant, right? Like that were not invented in either the ivory tower nor on Wall Street. So I think that conversation has opened up, but it's still happening, I think, even though it seems like it's at the center, in some ways at the margin of this conversation. And there are certainly a lot of places in the psychedelic world today where it's not being discussed meaningfully. Discussion is really only a first step. And I feel like in the I'll close by saying in the psychotherapy tradition of these like psychedelic approaches set in setting broadly, even which builds on like the Hubbard room, which is like in Los Angeles, this idea that you create this beautiful room with a couch. A lot of these things stem from indigenous psychedelic practices, right? So they're maybe secularized, they're anglicized, they're brought in, but they're syncretic to the extent that they build from analytic traditions in psychotherapy, they build from evidence-based traditions in psychotherapy, they build from various strands of psychedelic experience in support from indigenous lineages, and it's kind of amazing. And unfortunately, ownership and attribution are taken and have been largely for a long time. So look, we just celebrated Columbus Day, Indigenous Peoples Day, and I think that I feel like with the work, there's a lot of work to be done. Yeah, I'm actually feeling a little up. I mean, in my own reflexive practice, I've been asking like, what can we do? What can I do in this way to make a meaningful ask? The last part of this is really bad, is that so much of really hard is that so much of the underground work, with ayahuasca tourism there's this like really strong divide between above ground and below ground work, and much of the underground work is actually shamanically informed or trained work that's happening either abroad or even when practitioners come to the United States. So there's very complex things happening, and I feel like the barriers to entry and the barriers for meaningful reciprocity in the academy and in industry, like are huge and need to be dismantled.
Well, thank you. It's great to hear you voice your commitment to that, and especially in the positions you hold and are holding. So really appreciate the thoughtful response.
Thank you, Wendy. I appreciate that. Thanks for your work, and good luck with the upcoming study. I'm really curious to follow that. Good luck at the VA. Gianni, thanks for inviting me, and for everybody who stuck it out to the end. Psychedelics have changed my life for the better, and changed the way that I interact and live with other people, and have changed. I've been lucky enough to make a career in it. I don't know how that happened, but I get to do this full time. So it's really exciting to have so many people really excited about this, especially people with your background and passion and skills. So thank you for doing all that you're doing. I think that the future is brighter than I would have hoped for. So thank you so much for having me.
Thanks so much, Alex. Yeah, really appreciate all the nuance and thoughtfulness in all of your presentation and responses. And if you're up for it, I'm positive that we'd love to have you back, hear about the developments of these debates. But yeah, thanks everyone for coming, and thanks again.
Thank you so much. That was
Thanks,
wonderful.
everyone.
Thank you.
Thank you.
Take care, everyone.
Take
Good
care.
night.
Bye now.